technically part of the emergent resuscitative stage. And when we talk about resuscitation, we're not talking about cardiopulmonary, we're talking about fluid. Well, fluid resuscitation, it is the emergent phase, but they include pre-hospital because it becomes important when we talk about the amount of fluid, and that will make sense in about a minute, maybe two. So, in the emergent resuscitative stage, it's when the patient is first, seen after the event of the burning part. So, the first thing that has to happen is if it's a fire in the house, if it's whatever, safety first, and safety first for the person administering care, as well as safety first for the patient. But first you have to be safe. Not, in other words, if you don't know what the chemical is and you don't have gloves, you don't necessarily want to be touching a patient and putting yourself at risk because you don't know what you're touching, okay? If it's household bleach, that's one thing. But if you don't know what it is, you shouldn't be touching that. Generally, people don't jump into burning houses unless you're a fire person. Some people do. Last year a couple of years ago, there was actually a nursing student from Felician who jumped into a burning truck on Route 8, on Turnpike or Route 80, and rescued the driver and put him in her car and drove him to Hackensack. And she got like an award and she got a scholarship, and that was a nice thing to do, like to stop your car and jump into a burning cab of an 18-wheeler truck. That's very great. But we don't recommend it. We recommend that you stay safe first and then do what you gotta do. Patient needs to obviously be removed from the harmful situation as soon as possible. And just like any other patient, they're gonna be stabilized in ABC order. However, they also add D, E, and F for patients with burns. And the D stands for neurological or disability deficits. So looking for and assessing for injuries that are going to be neurologically or cause the patient long-term disability. The E stands for exposure. We want to keep this patient warm because we already said that the skin was number one, protection, and then the second part of protection is thermoregulation, because that's also protecting the patient. And if they've lost large areas of their skin, they are not gonna be able to thermoregulate. And they're gonna start shivering. When they start shivering, it increases the metabolism, and then the burns again begin to expand. So, we wanna keep the patient from shivering, we wanna keep them warm. If the only thing you have is a dirty blanket in the back of your car that's been there for 5 years, is better than nothing. Okay? Obviously, it would be nice to have a nice sterile sheet to throw home at them, but not many people are driving around with stuff like that in their car, or hopefully if they're in an ambulance, they do have something. But if it happens before an ambulance gets there, or before a fire truck gets there, or whatever, you're gonna use whatever you have to decrease the exposure of this patient. And then the third thing that you wanna do, the F part, is the fluids. And fluids are often started in the field, wherever that field may be, house fire, chemical explosion, I don't know, those are the two biggies that always come to mind. And in order to start fluids, you need to make sure, not you personally, but who's ever doing it, needs to make sure that they have a large bore needle. Do you know what that means, a large bore catheter? So what size would you think? 14 if they can get it, but that's very large for most
18?
patients.
20.
20. You could try to get an 18. And the reason is that we're gonna be running fluids at very, very high rates. So, they're gonna put a large large bore needle in. If they can't put a large bore needle in, they're going to, if the patient is young, they'll try interosseous fluids, where they put a very large needle into the bone marrow, through the skin, through the bone, into the marrow. You can't do that with an adult, because adult bones are too heavy, and the needle would never go through. So that's not an option for an adult. An option for an adult would be to do what they call a cut down. And a cut down is where they open the skin and they visualize the vessel and they put the catheter in. Or if they can get a central line of the patient. The other thing that often happens is that, if it's a home problem, we wanna make sure that family members have not like immersed the, burned skin into water. What happens when you immerse open skin into water? We said yesterday we're gonna wash it with Tepid, but we're not going to immerse it. What does immersing do, do you think?
So separate the skin?
Not infected, although it could, if you were putting it into something dirty that had water in it. I heard something.
Would it pull out the electrolytes?
It will pull out the fluid and the electrolytes and make the problem that we're going to have in the future, which is not enough fluid and electrolytes, worse. Because you just have open skin. And water is going to pull. It's kinda like when you go swimming for too long and your fingers get all wrinkly. Your fingers get wrinkly because they're exposed to water and the water is altering the fluid and electrolyte imbalance. Now, for most of us, it doesn't matter. You get out of the water, it goes to normal. For these people, they may not have that ability anymore because they're losing fluids all over the place, which we'll talk about in just a minute. So, no immersing, we don't wanna pack in ice, I said that yesterday. And if necessary, we're going to, their clothing is gonna be removed, because we don't want clothing to be burning into the flesh. And anything except cotton and wool, because those are natural fibers, is actually going to burn and melt into a wound. Because all of our polyesters, all of our rayons, all of our spandexes, all of our everythings are made from some type of plastic. So when they get hot, what does plastic do? Melts. And it's going to melt into the wound bed that is developing. If that happens, if you work in an ER and a patient comes in and they've got clothing on, you've gotta try to take it off, we don't wanna rip it off the wound bed. We wanna cut around it, take everything else off, cut around it, leave a piece of the material there if you have to. And then later on in the process, what they'll do is they'll try to soak it and they'll try to remove it without ripping it off. Because ripping it off will do what? It'll take skin with it, just that, because that's, right, when you do a wet to dry dressing, isn't that the purpose? You wet the dressing, you let it dry, it sticks to the skin, you take the dressing off, and it debrides the wound as you go. We don't wanna debride this wound yet. It's fresh, it's new, we don't wanna cause any more damage than there already is, so that will be left until later. But you do need to take the rest of the clothes off, because they're still often still warm, they're sooty, they can inhale the soot from the clothing that's burned, you want it off their body, if at all possible, to the best of your ability. They're gonna start at the scene, they'll start high flow oxygen, usually with a venti mask. Especially if they are expecting an inhalation injury. And then off, they're gonna go to the ER. So that's the start of the event. When they get to the ER, to the best of your ability as a nurse, you will try to get as much of a health history as possible. Now, sometimes that's not possible. The patients may not be alert enough, There may not be family with them, but you're gonna do the best that you can to get a history, because the history is going to impact the outcome. If you have a patient who is an uncontrolled diabetic, who now has a burn over 30% of their body, what's the first thing we think of? Healing. They are not gonna heal the way everybody else heals, right? So knowing that in advance can give you options that you may not have thought of, that you may not know you need. The patient's got congestive heart failure. They've already got a fluid problem. We have now added a secondary fluid problem. So knowing the history is optimal. It's not always possible. So just to keep that in mind. You wanna know when they get to the emergency room, what was done at the scene. Did they give them fluids? Did they need to do CPR? Did they need to intubate them? You hopefully would know that because they would have a tube down their throat. What happened at the scene? How long was the patient in the house that was burning before they got to you? That's actually one of the most important things, because time becomes important with fluids. Every single patient who is in a major burn event, and they consider that anything more than 15 to 20% total body surface area. So if they do that rule of 9, and they come up with anywhere between 15 and 20%, they immediately, it's considered a more serious, more major event. They may decide below 15% to still give a tetanus injection. Even if the patient is alert and screaming, I got one yesterday, they are going to give them a tetanus injection. Because there is such a high risk for tetanus developing in all of those open wounds that they'd rather give them a second vaccine than not, because the second vaccine isn't gonna hurt them. Okay, and that's the same with babies. I'm sure when you did peds, they told you that, you know, when you give vaccines to a child, if the mother doesn't remember, if they went to a different pediatrician, if they don't have a list of what the child had, they would give a second one, because it's really not gonna hurt them. Or if you have, you know, a 50-year-old who doesn't remember, oh, I don't know, when did I get that tetanus shot? Maybe yesterday, I don't know. So whatever it is, they're gonna get a tetanus shot. They are going to immediately, when they get to the ER, they're going to identify the amount of the body surface area, so the percentage of body surface area. They are going to identify the depth of each wound. So they're gonna classify each wound. Is it superficial? Is it superficial deep? What is it? They may even mark it on a chart that has a body, so that they know exactly where the wounds are. In the old days, we used to do that even with pressure ulcers. Every patient who had a pressure ulcer had a body slip in there, and you would put, you know, pressure ulcer A, pressure ulcer B, pressure ulcer C, so that you would know when you're talking in your chart, which one you're talking about, which one was getting worse, which one was getting better, what was working, what wasn't. And with burn patients, they do the same thing, because they want to be able to identify. Yesterday I said that superficial wounds do not count, but they would put superficial wounds on that body because they want to be able to look at them again and say, oh, this one has advanced to a deep partial thickness over the last 2 days. So they need to identify, and that's probably the easiest way to do it. If the patient wasn't intubated in the field, but they feel that there's enough of a indication that the patient had inhalation damage, or if the patient begins to exhibit symptoms of respiratory problem, they will intubate the patient. They may first do a bronchoscopy, but they will do an intubation for sure. The next thing that has to happen is the actual fluid resuscitation. And I'm breaking my rule for the phone because I looked it up last night and then I didn't write it down, because I want you to have the formula for okay. We'll get to that momentarily. So, the fluid resuscitation, there are a bunch of different formulas, but the most common is called the Parkland-Baxter formula. It's actually was developed at the Parkland Hospital in Dallas, which is actually where President Kennedy was brought after he was shot. They developed this formula to treat patients with burns because they noticed that a lot of their burn patients were going into hypovolemic shock and dying. So they developed this formula so it would be more standardized, and it's pretty much the standard. So the formula itself is the volume, so the amount of fluid, the volume, is equal to 4 times the patient's body weight in kilograms times the area, so the percent, the total body surface area, times 100. Now, if you're into math, which I already told you I'm not, and yesterday proved that when I tried to explain the math test, the A and the times 100 are in parentheses. So that usually means mathematically that gets done first before you do the other pieces. So I was gonna, I can write it on the board. I'll write it on this board. So V equals mass, which is in kilograms, times, what did I say? Times 4, and then times the percentage times 100. Okay, so that's how much, this formula is gonna give you how much fluid the patient will get during the time of fluid resuscitation. Now, fluid resuscitation only accounts for the first 24 hours of a patient's burn event. So V, volume, I know you guys over in that corner can't see that, equals mass, which is their body weight in kilograms, times 4, that's standard, times the area times 100. Okay? The reason that that's important is because we can see in a minute how big numbers can get that patients are going to need in that first 24 hours. So for that formula though, what you need to know first is when that first 24 hours started. And that first 24 hours starts when the patient gets burned, not when they get to the hospital. So, if it's a terrible fire and they find this person underneath rubble 3 hours later, and then it takes an hour to get to the hospital because they can't extricate them, we are now 4 hours back already. That 4 hours back is going to change the amount of fluid a patient gets per hour, because we need to get a certain number of, we need a certain amount of fluid in a certain amount of time, okay? And I'll tell you what that time is in a minute. But you must start when the burn happened. Now, for us who live in the New York metropolitan area where you can spit and there's a hospital, literally, on every corner, right? We're very lucky. We could, some of us spit further than others, but we have multiple hospitals in a very close range. You go out to the Midwest, sometimes, other than a small, tiny, little doctor's office, you could be 3 hours from a hospital. Just to start with. Makes a huge difference. Huge difference. So oftentimes, this is started at these tiny little places, and then they'll transport the patient. Because it's more important to get the fluid going than it is to get them wherever they are gonna go for the final destination, even though it's not a vacation. With the Parkland formula, once you figure out how much fluid the patient actually needs, and you don't do that, the doctor does that, but you should be aware of it so that, again, it makes sense in your head. But once they figure out how much fluid, that volume is just the volume for the first 24 hours. And the patient will get half of that total volume in the first 8 hours of the day, of their 24 hours. So let's just pick big numbers that divide evenly so I don't have to get confused. If we start with the V ends up at 10 liters, which is possible. For an adult male, 10 liters is not like an astronomical number. Normally, how many liters do we give in a day for a patient who's dehydrated who needs fluids? Maybe 2. We're talking 10, sometimes 12. So we'll stick with 10, it's easier to divide. So if they're gonna get 10 liters of fluid in the first 24 hours, in the first 8 hours, they need to get 5. Now, if you've already lost 4 hours because they didn't get to the hospital immediately, you now have to give 5 liters in 4 hours. Do you understand why you need a large bore needle? You could never get that amount of fluid through a 21, a 22, whatever. Come here.
Question, how about, isn't the patient going through fluid overload?
No, because, we'll get to that next. We'll get to it now. When the patient gets burned and their vessels are impacted from the burn, so remember we said yesterday with the different levels, all the vessels are in the lower level, and when it gets down there, those vessels lose their ability to move fluid. And what happens is, fluid actually moves out of the system, and it goes into second and third spaces. So second and third spaces are our skin, our peritoneal cavity, our pericardial cavity. Depending on the extent of the burn, the total body surface area, this grows exponentially. So they kind of look like the Michelin tire man. They're all blown up. Bless you. But their fluid is not in their vascular system. Their fluid is in their tissues. So that's where the hypovolemia comes in. It seems completely and totally crazy because they look blown up with fluid. They look overloaded, but they're not vascularly overloaded because the fluid's in the wrong place. It's in the skin, it's in the tissue, it's in peritoneal cavities, it's in pleural cavities, it's all over. But it's not where it's supposed to be. Bless you.
Thank you.
Now, are there exceptions to that? Sure. If you're gonna give 10 liters to a patient with already has congestive heart failure, you have to be a very astute nurse to make sure that we are not overloading them. That even though this is what they need for their burn, for everything else going on, it may not work. And then you have to have a conversation with the physician. to say, listen, I know the formula says they have to get these 5 liters in 4 hours. But between 10 minutes ago and now, the patient's already starting to develop crackles in their lungs. What do you want to do? It's not your decision to decide what to do. It is your obligation, and it is absolutely part of our job to inform them, because they're not the ones listening every 5 minutes when the patient is critical. It's you, as the nurse. So we absolutely need to inform them, but 9 times out of 10, they are not overloading vascularly because of where the fluid actually is. They get so edematous. Do you remember the pictures I showed yesterday, some of their little hands? They were like balloons, and that's because the fluid moves. The damage to the cells causes the dumping of all of the internal workings of the cell all around, in addition to killing cells next to it. The other thing it does is it dumps sodium, it dumps everything that's outside. So then once it dumps sodium because it's damaged, then where's the water gonna go? Water goes with sodium, right? So the more cell damage you have and the more sodium you're losing, the more edema you're gonna have. And the more edema you're gonna have, the less you're gonna have in your vascular system, and the higher the risk for hypovolemic shock. Does that make sense to everybody? Okay. So these numbers can be really huge. And think about if you have a morbidly obese patient, and it's weight dependent. These numbers can be gigantic. But you have to figure out what it is, and again, not you, the physician will figure it out and say to you, this is the order. Your job to get it in them. But it's your job to get it in them while you're assessing them to make sure we're not doing further damage in another place. Okay, does that answer the question? Okey doke. So, and the fluid they're going to, the first 8 hours, they get 50%, half of the total volume. The second and third 8 hours, because 8, 16, 24 hours. And the second 8 hours and the third 8 hours, they get a quarter of the total. So we've given 50, there's 50 left, then they get half and half. Because what we wanna do is we do wanna flood them with fluid as soon as we can to make sure their organs don't shut down, because then what happens, right? If vascularly the patient is shutting down because their fluid isn't there, what happens to the blood that is in the vascular system? It gets really thick and viscous, right? So if it gets really thick and viscous, what are they at risk for? DVTs, blood clots. They're also at risk for the blood not circulating properly. So if the blood's not circulating properly, what's happening to the end organs where it's going? They're dying, right? You're gonna have liver failure, you're gonna have your gut shut down, you're gonna have renal failure. Everything is going to shut down because we've got this thick gunk going through our veins instead of nice liquid blood, because the liquid is in the tissue. So in order to give this patient the best chance possible for survival and good survival, we don't want the patient to survive and then have to be on dialysis for the rest of their lives, or need a liver transplant. We want them to survive and survive well. So the best chance we have of doing that is making sure that the fluids are maintained so that they're at least getting something perfusing them. It's not the best, because what happens, even though the blood is really thick, what happens to the hemoglobin and hematocrit when you lose the fluid that's in the blood? When you get really viscous blood, what happens to the hemoglobin and hematocrit? It increases, right. It increases because now when you take a blood sample, you're getting this very concentrated, but it's a false high. So you may get a hemoglobin where the hemoglobin is like 18 or 20, but it's probably closer to 12 in reality. So you need, when you look at blood work, you also have to take into account that we're taking blood that is not as loose as it normally is. So we're getting very concentrated numbers that are false. Okay? Are you all with me? Okay, so, and the fluid that is most commonly used first is lactated ringers, right? Makes sense. What is lactated ringers? Anyone know? Isotonic with electrolytes. And a lot of electrolytes, so it's different than just adding 20 of K to a bag of D5 half or to a bag of saline. It's a heavier, right, from an osmolarity perspective, it's we call a heavy fluid. It's heavy because it's got a lot of stuff in it, and it's not just going to, it's going to add to the volume that's in the vessel. That's what we want it to do. So, the other things, they may give IV, they may give something called Dextran. Dextran is like an albumin. Again, albumin's heavy, right? It's heavy. So it's going to hold on to whatever fluid is there and stop it from going out. That's not usually done until like the second, after that first 8 hours. So that first 8 hours, it is strictly lactated ringers. After that, they'll begin to add some other things. All right. Okay, so that's the fluid resuscitation. The other things that you might see during that time in terms of medication, believe it or not, you might see mannitol. Right, so it sounds like we're crazy, right? We're dumping all this fluid in, and now we're giving mannitol. Why would we think about giving mannitol? We wanna keep, right, we wanna keep those kidneys perfused, and we wanna keep the kidneys working and putting out urine. Because when all that fluid is out in the system and the blood is not running correctly through the kidneys, urine output drops. Urine output drops, and then we're gonna have a problem long-term with kidney failure. So in order to keep all of that going, they may give some mannitol so that we have enough urine coming out. What's normal urine? 30, right? 30. When a patient has a major burn, we want to keep the urine output between 30 and 50. If it drops below 30, it means we're gonna have a kidney problem. If it goes above 50, it means we're gonna dehydrate the patient. This is a very sick patient. And they need all the fluid they can get. If they start all of a sudden, if you give, doctor orders 25 grams of mannitol, you give them the 25 grams of mannitol. Next thing you know, you look out and they put out 80 cc's in the last hour, because this is the patient that you're going to be checking urine output every hour. You need one of those Foleys that has the urimeter, you know, that hard urimeter on the outside. And you're gonna be checking it every hour. You notice that, since I gave that mannitol, they put out 80 cc's this hour. That's not so good, because now I'm losing the fluid that I'm giving them to keep their vascular status open. So then it's time to make another phone call if the doctor's not right there and say to the physician, look, their urine output since that mannitol has really taken off. And they might actually say to you, okay, we're gonna increase for an hour, we're going to increase the fluids for 1 to 2 hours to X, whatever, so that we can now balance that. Call me back and let me know what it is, because mannitol works within in the first 5 to 10 minutes, that's when you see output. After you give mannitol, you'll see urine output increase within 5 to 10 minutes, but it also lasts a very short period of time. It only lasts about an hour. So within an hour to 2 of increasing your fluids, it should balance out. And that's what we're looking for. We wanna keep that urine output between 30 and 50. We don't want it to go lower, and we don't want it to go higher. Otherwise, the only other medications may be respiratory medications. They may give them bronchodilators, especially if there's the possibility that they had an inhalation injury, and they would give bronchodilators early. There'll be plenty of other medications, don't worry. Okay, but that's fluid resuscitation. The next 24 hours after that is not as prescribed. That really is based on the patient and the patient's history and where they are. So they will decide fluids after that. There's no formula. After that, it's based on patient need. But the phase of fluid resuscitation, or the emergent phase of burn care, ends when urine output begins to increase without any other intervention. So it means the kidneys are getting perfused. It's our best way of knowing that the kidneys are now working on their own. So it's not going up and going down and going up and going down. It's staying at what we anticipate, 30 to 50 an hour. The kidneys are now open and functioning, and the emergent phase ends. And the acute phase will begin. Yeah, put your mask down so I can hear you.
So with the mannitol, or is it like on their own, will they be able to?
On their own, with no intervention. And they probably wouldn't give more than 1 dose of mannitol. They could use it again periodically, but in that emergent phase, they would probably only do it once. All right, I'm gonna change this so I know what it says. I know you don't know what it says. Yesterday they were here so fast. Today, not so much. Okay, we did this. All right, so, I'm pretty much already close middle. And I'm looking again. I just like, what's the habit? I'll go this way. All right, so, the system alterations that we're gonna be seeing from a cardiovascular standpoint, we already talked about the fluid chips. I shouldn't have, do I have to talk about them again? Yeah, maybe? We're good? Fluid chips? Okay. And we also talked about the electrolyte chips, because when the sodium starts to leave the system, it goes out into the tissues with the water, or the water goes with the sodium, really. And what does that leave in the vessels? If sodium's out, what is the big electrolyte that's left? Potassium. So the patient is hyponatremic and hyperkalemic. It's another way to know whether or not your fluids are getting back in balance, is when those start to get back in balance. And usually what happens is when, at the same time that the urine output is picking up to end this phase, what happens is the sodium is beginning to move back into the vasculature, and the water is now going with it. So the edema is going to decrease, it's not gonna go away, but the edema is gonna decrease. The fluids and the sodium are gonna go back into the vasculature. The downside to that is, we have been giving them a whole lot of sodium, haven't we? Like giving them lactated ringers and normal saline to keep their pressure up and all that. So now, toward the end of the emergent phase and the beginning of the acute phase, they are hypernatremic and hypokalemic. You could see where this could take you all day to just take care of this one patient, maybe two of you taking care of one patient. And most of this, for the emergent phase, is actually happening in the emergency room. So imagine being an ER nurse where you have other patients and other things going on, and you still have to keep this kind of close eye on one burn patient. Hopefully there's enough staff that doesn't have to happen if you just stay with the burn patient. So are there any questions on that big system? We're good? Okay. The immune system, we already said that the first protective barrier is interrupted because there's all these holes in the skin because the patient is burned. The other thing that happens is that immunoglobulins are proteins that are part of the blood that have to do with your immune system. You will learn about those in the next half. We don't need a whole lecture on immunoglobulins. But what you need to know is that immunoglobulins normally circulate all the time for all of us. And when you have a major insult like a burn, what happens is due to the stress of the event, physiologically, a lot of things change. And one of the things that changes is that immunoglobulins drop. The body doesn't produce them as fast, and there aren't as many circulating in the system. There are also, again, physiological response to stress is the bone marrow begins to put out a lot of immature white cells. Because it recognizes that there's this big assault on the body, and it says, oh boy, we need white cells, but it doesn't have the time to let them get to maturity, and it just pulls out all of these immature white cells. And the immature white cells can't really work very well yet. So the numbers of the white cells may be normal or high, but they are not, most of them are not functional white cells. So you have decreased white cells function, we have decreased immunoglobulin function, and we have no skin. So this patient is immunocompromised. So they are very, very high risk for infection. This is why they are often in private rooms. And you're gowning and gloving to protect them. Different. Normally we gown and glove to protect us from whatever the patient has. In this case, we're gowning and gloving and masking, well, we're masking all the time anyway, but extra masking because what we want to not expose this patient who literally, if you sneeze on them, could die. Because they have nothing to fight anything. Their body is not working normally yet. Hopefully it one day will. Sometimes can take a year. Hormonal changes that occur. In this case, we're not talking about that. We're talking about, which hormones do you think I'm talking about? Come here.
Cortisol.
Cortisol, what else? Anybody? Samir, you have any else? I didn't mean to cut you off. The adrenal hormones, so things like I can't even talk. Aldosterone, right? And ADH. Because both of those have to do with water, right, and sodium. So, when the cortisol goes up in relation to stress for all of us, right? That's what cortisol does. And that's going, until that comes down, some of these other processes continue, like the white blood cells and things, oh, I thought that was our time, it's not. So until the cortisol starts to drop and the body is not in this constant state of fighting this physiological assault, then we're gonna have trouble with everything else, so that goes up. The aldosterone, when it goes up, the aldosterone goes up. And that causes the kidneys to do what? What does aldosterone do? In relation to water, do you remember? Aldosterone conserves sodium. So now, I said before, the sodium went out to the tissue with the water, with the fluids. We're giving them all kinds of sodium in the lactated ringers and then eventually normal saline to keep their pressure up and stuff. And then we have the aldosterone holding on to sodium. So as much sodium is in the vessels, they're gonna try to keep it there. Then when the fluid goes back, they've got all this, besides what we're giving them, they've got all this extra sodium that's been held onto by the aldosterone. So it's gonna add to the hypernatremia as this begins to resolve. And then the ADH helps to conserve fluid. So the urine, the kidneys don't wanna put out any urine. We want them to put out urine. The kidneys are working against us and don't wanna put out any urine because they're conserving it all, because the kidney is acting in response to the fact that there's only this thick, viscous blood perfusing it, and it's not enough to make urine. So it says, uh-oh, something must be wrong. I better hold on to every molecule of water that I can possibly hold on to. And then we get no output, or we get even less output than we had. Hopefully that will get reversed by giving all these fluids during the resuscitative stage. And eventually the patient will even out. But those are the processes that are going on to complicate, or maybe not complicate, but to add to the fluid problem that we're already having by the fluid being in the tissues instead of in the vessels. Yes? No? Maybe? We're good? Okay. GI system, oh, I know what else I have to say about fluids. Patients can develop permanent damage to their kidneys from all that sludgy, thick blood that gets stuck in the kidneys. It gets stuck in the tubules as it's going around the tubules and trying to get out. It literally gets stuck because it's like mud and it gets hard. And the sludge will then, if it stays there too long without being flushed out, if we're not successful with the fluid resuscitation, and that area of the kidney will die and become necrotic. So you get tubular necrosis because of the sludge that's sitting there. So another good reason to keep our fluids going appropriately. The GI system, the same as the kidney system, the renal system, is also not getting perfused. It's not getting perfused because of the same sludgy blood that's not doing us any good. So the patient runs the risk of developing a paralytic ileus initially, and possibly necrosis of part of the gut if that sludge continues for a longer period of time. So just like the kidneys can die, the gut can die. The other thing that happens in the GI system from the stress of the event is they develop an ulcer, and that ulcer is in the stomach or the duodenum. And this is different than an ulcer that you discussed in GIGU, because that ulcer is almost always caused by what? H. pylori. These are not H. pylori, these are definitively related to the physiological stress that's going on, and they're called Curling's ulcer. C-U-R-L-I-N-G, Curling. Because Dr. Curling noticed that his burn patients were all developing ulcers, so they named it after him. That was nice. From a respiratory standpoint, we also worry about the decreased blood flow to the lung for the same reason, because we need blood flow to the lung, just like we need blood flow to everybody, every other part of the body. But what we worry most about are smoke and inhalation burns, and the smoke and inhalation are two different processes. Smoke damage is from the toxins that are in the air during the fire or with the chemical explosion, generally not with radiation. Generally not so much with electrical injuries, but with thermal injuries and with chemical injuries. And it's the most important determinant of mortality in patients with major burns. If they have an inhalation component, or if they have a smoke component, it's responsible for 60 to 70% of the patients who die. So of those patients that have a problem with the respiratory system from the burn, 60 to 70% of them will die from that event. So it's really important that we're paying close attention to the smoke and inhalation issues that are going on. The first thing, in addition to the toxins that are in the smoke or in the fumes that the patient is experiencing, if they're actual smoke and it's actual toxins, the soot gets stuck in the lungs. And you can actually Google and see pictures. But when the soot gets in the lung, what the lung tries to do is it tries to wall off the soot if they can't get it out. So if they're not coughing, if they're not coughing and doing deep breathing exercises and they're not able to get it out, what ends up staying in the lung literally builds like a membrane around it. It builds a wall around the soot. And when it builds this membrane in the lungs become less pliable. They can't expand. That's really what fibrosis is. Fibrosis, that's the process of fibrosis, is the development of this membrane around bad things in our lungs. And the lungs get fibrotic, they get a lot of fibrous tissue, and then they can't expand. You can't get air to the alveoli, so you don't have exchange of oxygen, and the patient becomes compromised for the rest of their lives. And when burn patients cough up sputum, you can actually see black soot in their sputum. So that is one of the things that we're gonna look for when we suction them, or if they're coughing. The other thing that we have to worry about with smoke inhalation is what?
Carbon monoxide.
Carbon monoxide. What, do you know what the physiological process is with carbon monoxide?
It connects to the hemoglobin, and it has more affinity than oxygen.
Right.
So you gotta give a rebreathing mask with 100% oxygen.
Right, so hemoglobin and carbon monoxide compete for the same receptors on the hemoglobin molecule. And oxygen loses out every time carbon monoxide is present. So what ends up happening is the carbon monoxide ends up being delivered to all of our organs instead of oxygen, and then they die from carbon monoxide poisoning. But they don't have oxygen in their system, they have carbon monoxide. The one way of assessing that, and if it's occurring, is to do what they call carboxyhemoglobin levels. CARBOXY hemoglobin, carboxyhemoglobin. So that measures the molecules that have carbon monoxide on it. So carboxyhemoglobin. And they do them serially. So they'll do it when they come in, they'll do them a half hour later, they'll do them a half hour later. And if they're going up, they will intubate. If they stay level, they might just leave them on a venting mask. And the reason I said earlier, they would be on like 100% humidified oxygen, I don't know if I said humidified, but it would be humidified. 100% humidified oxygen is because we want there to be more oxygen available than there is carbon monoxide, so it can kind of bump them off and get a couple that are left open. So either intubation or the 100% humidified oxygen. The other thing that happens with smoke inhalation and heat inhalation, we'll call it that, because they're inhaling all the hot air, is that they get inflammation of the trachea, all of the bronchi, the bronchioles, all of that gets inflamed. And what did we say yesterday about mucous membranes? They're all mucous membranes, right? So they are all at very high risk for severe inflammation, which is why they would want to intubate them early. Because that trachea is gonna get so big that they're not gonna be able to get a tube down. And it's not gonna get, the lumen isn't gonna get bigger, the tissue is gonna get bigger and swell. There are also two things that you need to think about with the lungs. There are what we call upper airway injuries and lower airway injuries. Upper airway injuries occur above the glottis. They're usually thermal, so hot air, steam, smoke, things like that. The primary problem with these are the mucosal burns of the oral pharynx. So blisters develop, it gets red, edema develops, that edema peaks in 24 to 48 hours, and it can cause a mechanical obstruction. Remember I said that yesterday, that we would look at that, and if it looked like the mouth was involved, they're gonna intubate early also. Because it will mechanically obstruct the oral pharynx to the trachea, and then the patient will not be able to breathe. So this is when we're gonna look for the singed facial hair, the hoarseness, the difficulty swallowing, all those things that we talked about a little bit yesterday. Lower airway injuries generally occur when there is an explosion. And the reason for this is that our glottis, well, there are two things, explosion, and if the patient is unconscious. In an explosion, the glottis gets blown open from the force, and the hot air and everything goes down into the lower airways. If the patient's unconscious, the glottis relaxes, and that's when all the hot air and the soot and everything goes down. What they use to diagnose this is called a xenon, X-E-N-O-N, xenon perfusion scan. And it uses xenon, which is a gas, to look at the damaged areas of the lung. So for patients with inhalation problems, we're gonna do all the normal things we do for patients with lung problems. They're gonna be in a high Fowler's, which is 30 to 45 degrees. We're gonna do coughing and deep breathing if they're alert. If they're not alert, we're gonna be doing suctioning. we're going to be doing turning and positioning. All of those normal things that we would do have to be done to this patient as well. Okay, so moving on. Metabolic changes that occur. There are two phases of metabolic changes. It's called the ebb and the flow, like a wave, the ebb and flow of a wave. So the ebb phase is the first 3 days. This is when physiologically the patient is in protective mode. Their body goes into protective mode. Ebb, EBV, ebb phase. First 3 days, so decreased oxygen use and need, major fluid imbalances, decreased circulatory volume, all of which we've talked about, and shock. And even though these are not good things, they are actually protective to the body physiologically. Right? We're gonna slow down our metabolism. We don't wanna use too much energy, too much oxygen. The fluid imbalance is looking to be corrected. All of these things are protective. The flow phase, FLO, not slow, SLO. The flow phase is the second phase, and this happens after fluid resuscitation has been successful. So we usually say 3 days, because that's an average. Now the body has increased energy needs, because now it's gonna start to heal. And in order to heal, we need increased energy. This is when the first time we're gonna start worrying about nutritional things, because the body will break down, first it'll break down proteins, then it'll break down the glucose and fat stores in that order, but we'd rather give them enough so that they're not breaking anything down. So we wanna make sure nutritionally that they are intact. This is when the patient can have a dramatic loss of weight, which for some of us would be wonderful, but it's not the right way to do it. And it's not healthy for the patient. They need to maintain their body weight. They also might end up with a negative nitrogen balance. Do you remember that from nutrition? So this is considered a hypermetabolic state. And this flow phase lasts until the wounds are closed. So for some people, that's, I said yesterday that some of them, within 2 weeks, they heal. Others, they take longer and they need grafting. So depending on the patient's situation, that will depend on when this flow phase completes. During that time, we will talk about nutrition, but not quite yet. But they may need TPN if they can't eat enough calories. If they have a working gut, they may do enteral feedings first and then do TPN. It depends. Because the rule of thumb is if you have a working gut, then you should use it and not just go to TPN. You also all know that when you have TPN, you also must get fats. Did you cover that when you did GIGU? That little bottle of lipids? Because if you don't get the lipids, you kill your kidneys and your liver. Which they found out after years of giving TPN without it. And then they were having all these patients with liver and kidney problems, and they were like, what is going on? And there was not enough fat, because there was no fat, it was all proteins. It was like a total keto diet. And so there was all this other damage going on. So once they started adding the lipids to it, people evened out and they could stay on for longer periods of time without a lot of significant damage. Okay, the renal system, we already kind of talked about in depth. Do I need to talk about it again? Urine is either dark brown if it's, and concentrated if it's present. If it's not present, then it's a bigger problem. what happens to specific gravity of concentrated urine? Do you remember? Goes up. Okay, so we're gonna have high specific gravities. The red and the rusty color from the, in the urine, in this case, may be due to damaged hemoglobin because of the damaged vessels. And this is what adds to the sludge in the kidneys. We also have the breakdown of muscle, if muscle is damaged. And in muscles, we have myoglobulin, which is what's found instead of hemoglobin, which is in the blood. We have myoglobulin in the muscles. That is also a very heavy molecule, and if there's a lot of muscle damage, that will also stick in the kidneys and cause problems. Okay, so during this whole emergent phase, with the patient, if they're able to talk, will also often complain of thirst because of the dehydration. Because even though I said they look like the Michelin Man, and they're all blown up with edema, they have nothing in their vasculature, so it makes them thirsty. They develop blisters, which is another third spacing, right? Third spacing, we said, what is third spacing when I say that? Anyone know? Fluid shifts into spaces. Second spacing is fluid into tissue. Third spacing is fluid into spaces. So any place you have a space that fluid doesn't belong, if you have fluid there, it's called third spacing. So pleural cavity, pericardial cavity, not really a cavity, but the space between the heart and the pericardium, the space between the lung and the pleura, this peritoneal cavity, all those things are all third spacing, and blisters, because blisters separate the levels of the skin. That's what happens, it's in the wrong space. It's not necessarily in the tissue, it could be also, but once you see a blister, blisters start at third spacing. The decreased or absent urinary output and the paralytic ileus that we talked about. So those are all signs and symptoms. Those are all things that you need to keep an eye on. And when those things begin to wane and they begin to get resolved, then we're gonna begin to move into the next phase. So diuresis is usually the easiest one to track. So when diuresis starts, when they start really putting out more fluid, and the specific gravity of that fluid starts to go down, then we can move on to the next phase. And then just some quick other things that might happen during the emergent phase. You might need, the patient might be vented, so you would need to take care of the vent. Need to make sure that we remember just general positioning and turning patients on a regular basis. Respiratory toileting, which is what we call the cupping and clapping that respiratory therapists do now, but also making sure that we are suctioning appropriately if needed. Obviously, if they're vented, they have a tube, either a trach tube or an ET tube, if it's gonna be short term, and making sure that we know how to care for them properly. We wanna make sure that the air that they're getting is humidified, otherwise everything gets dried out, and then the tissues crack and break open and get lacerated, and then we have infections, so we wanna make sure that it's humidified. And then I already told you the bronchodilators. If they are suspecting a great deal of viscosity, there's a lot of congestion in the lungs, they may give the patient mucolytics as well, MUCLYTIC, mucolytics, to decrease the viscosity so that they can get sputum up. And IV fluids and pain meds. will break. I am a little concerned about finishing, but I will give it to you. Otherwise, we can keep going, and I'm pretty sure we can finish it all. Break, no break, let's keep going. I'll keep going. Up there again, nope, nothing, over there. Okay, burn shock, like there was spinal shock. Burn shock is when a patient develops shock due to a burn event. It usually happens in the emergent phase. However, it can also happen as they're moving into the acute phase. And it really is there's really no difference between burn shock and hypovolemic shock, except for where the fluid is. In hypovolemic shock, we usually think of loss of blood, right? It's out of the body somewhere. Patient has a major GI bleed, and they go into hypovolemic shock. In this case, the patient has hypovolemic shock, but it's due to the fluid being in second or third spaces. But you get the same symptoms as regular hypovolemic shock. So you're gonna get tachycardic, the blood pressure's gonna drop, then you get diaphoretic. Okay, so it looks exactly the same. It's just the causative factor is a little different. Right, so the acute stage of burn is the second phase. The time frame for this phase is from the time urine output begins to get back to normal on its own without resuscitation. And it lasts until the wounds are closed. This is really when it becomes very multidisciplinary in terms of care. And the reason for that is prior to that, during the emergent phase, we're really trying to keep the patient alive. And we're not worried about their nutrition, we're not worried necessarily about their psychosocial status, we're not worried about any of those other things. But once the acute phase comes, we worry about that kind of stuff a lot, because this phase can last anywhere from a week to a year for some patients. And you have to deal with families during this time, and it's just a little more complex. So this is where the whole team can come into play. So diuresis is occurring and the edema is decreasing. The paralytic ileus, if they've had one, is beginning to resolve. The kidneys are opening up. The area of the burns has stabilized. Anything that's gonna get bigger has already gotten bigger. And unless they get an infection in that wound, now we hope that they're gonna get small. Because infection is the other thing that can make those wounds get bigger. This is when they will evaluate which wounds they think at this moment are going to need to be grafted, which ones they're pretty sure are gonna heal on their own. And this is also when psychosocial issues begin to pop up with both the patient and the family. You know, before that, they're all worried and anxious, and they don't want them to die. And then they kind of go over that hump, and then they're like, okay, why did they run into that burning building? They're like angry. They're angry at the person's angry at themselves. There's a lot of anger going on. And sometimes that anger gets directed at us as the nurses, and we have to, you know, put up that little bit of a shield and say, they're really not, it's not about me. They're really just angry, and I am, not that you have to take it, but they're dumping it on me. But if you're not gonna take it, you have to be able to say to them politely, I understand you're upset. I'm doing the best that I can for whoever. And I know you're not really angry at me. Sometimes you actually have to say it. But getting all annoyed and pissed off is not the way to go. Like, don't yell at me, you're mad at them. Like, that doesn't fly. It's not good. So don't do that. During this phase, we're going to be doing more with cultures and sensitivities of both the wounds and sputum. And if it looks like the patient's getting sepsis, then blood cultures as well. We're going to be looking for ongoing hemoconcentration, but not as severe as it was in the acute phase. We said that the patient is gonna be hypernatremic and hypokalemic when the fluid starts moving in. So we're gonna have to watch for that and make sure that we're appropriately addressing all of those things. Okay. During the acute phase, there are some areas of nursing that we're going to pay more attention to than others. One of those is pain, because we already said that even though the rule is full thickness has no pain, every one of these patients, no matter what we do to them, hurts. It just hurts. They've got burned, irritated nerve endings that are constantly firing. And then we go to wash them, and it hurts. We go to get them out of bed, and it hurts. Everything we do to these patients hurts. So we need to make sure that we are very astute in our pain assessment. You all know, I hope, that even for patients who are unconscious, and sometimes burn patients they use conscious sedation to keep them out, so that they don't experience quite as much pain, number one, and number two, that the body can just relax and heal physiologically. But we must always assess pain, and there are pain scales to assess people who are nonverbal. They use them in ICUs. They look at things like, and it's not just like the happy face for the kids, because some kids are nonverbal too. But these are nonverbal, primarily nonverbal adults. But you look at things like agitation. You look at things at involuntary arm and leg movements. They're out there. Like when you go on, I know in Epic at Hackensack, if you look at pain, when you're documenting pain medicine, it asks you which scale you used. And if you do the drop-down box, it will give you some of the nonverbal scales that they use there at that hospital. So they're out there and they should use them. Just because the patient is sedated or unconscious, like even unconscious people have pain. And we need to make sure that we're assessing for the clues to that pain. So pain management becomes one of the more important things that we do for these patients. There is both physical and psychological pain. They both need to be treated. Generally speaking, pain medication is given IV for these patients because either there's not enough M for an IM or a Q for a Q. And there is also the thought that we don't want to be inflicting pain to take pain away. But that's a hospice thing. I don't always agree with it. But, you know, hospice very rarely gives a sub-Q or an IM injection because their philosophy is, why are we going to add to the pain with a needle? So they'll use other methods. Sometimes, I think, personally, you need a quick shot to kind of get them over the hump, and then you can figure out the rest, because nothing is going to absorb like an IM or a sub-Q unless it's IV. But when you're home and you've got a patient on hospice, you don't always have IV access. So we do want to make IV is usually the route that we go. If they're not doing IV and they still have a lot of wounds, then you can do the buccal or buccal, where you do the liquid drops in the side of the mouth, by the buccal membranes, and they will absorb it. And there are primarily, I think there are 3 drugs that are available that way now. And last but not least, you could use a patch, but the patch can present a bunch of different problems. First of all, you have to have enough skin to put the patch on. That's number one. It's gotta be flat enough. Second thing is if a patient's temperature is variant, they will get more medication if they have a fever. Because the blood vessel, right, how do we get, and this is true even, like, if you give a what do you call those things? The NitroBid patches, have you seen those, where you give nitroglycerin on a patch? If a patient has a fever, what happens when you have a fever to your blood vessels? They dilate. How do all of our transdermal medications get absorbed? Through the vessels, right? They go through the skin, into the vessels, into our system. That's how they work. So if you've got dilated vessels, they pull more medication in during the time of the fever. So it may not be as even as people think transdermal is. The other thing about transdermal is there's been research out there for like 5,000 years. Well, not that long, obviously, but, they were designed and marketed for changing them every 72 hours. We absolutely know, without a doubt, that they only last for 48. So when your patients have a transdermal patch for pain, or even for nicotine, they don't last the 72 hours that they think they last. Because they've done studies and they've done blood levels of the drugs. And we know that after 48 hours, they are almost gone. And then people think, oh, you know, they're looking for meds, it's supposed to last 3 days, and the answer is no. The patch just only lasts 48 hours. So it's just something to keep in the back of your mind when you go out there to practice, when you go out to practice. For pain, if the patient is alert enough, you can use non-pharmacological adjunctive types of things. So things like visualization, music, guided imagery, all that kind of stuff. If they are not alert, they're clearly not gonna be doing that. But you can also add things if they don't seem to be totally responding to the pain medicine. You can add things like sedatives. So things like Haldol, Valium, Ativan, Versed, all those things. And if by chance you have a patient who has had a narcotics problem or currently has a narcotics problem and they are still in severe pain, they may need enormous doses of narcotics to combat that. But you can also give a narcotic antagonist, so you can give Buprenex for those people who are not narcotic naive. That means they have a history of narcotics and narcotic use. And sometimes that'll break through the cycle and it competes for the receptors, and they will get much better pain relief than if you're using gigantic doses of a drug that they've already become accustomed to. So just other options that we have out there. The second most common problem for patients in the acute phase is infection. This is where we really, really worry about whether or not they're gonna die of sepsis. Emergent phase, they're gonna die of respiratory failure. Patients in the acute phase they're not gonna die from pain, but they're gonna be very uncomfortable, but they can die from an infection. It's the most common complication, and we have to worry about both systemic, meaning a sepsis, or local infections of the wounds. And each wound, believe it or not, can actually have a different organism, depending on who's touching what wound. You know, you come in and you have this on your hand or on your gloves, and this happens, and then somebody else comes in and they have a different bug and they touch a different wound. So, I already said that if a wound gets infected, it can expand, so it can go deeper or it can get bigger in terms of area. If the patient has that dark, leathery skin, have any of you, I'm sure, not that many, how many of you have seen like a black heel, where it's totally black and leathery, no, really? pressure ulcers that get black and yucky. And the tissue is actually hard. They call that eschar, E-S-C-H-A-R. And it really is like leather. It's like you tap on it and it actually has a sound, like. And sometimes when you have patients that have that kind of a wound, what happens is between that eschar and the wound bed down here, in the middle develops infection. And you don't see it for a long time because it's under this thick, heavy wound. So sometimes what they'll do is they'll actually cut that eschar so that they can drain, or so that we can be aware if it starts to drain. That's called an escharotomy, where they cut the eschar. Sepsis is sepsis. You should, I'm pretty sure Professor Coney does sepsis. The most common organisms in burn patients that we have trouble with are Pseudomonas, Staph, Klebsiella, Enterobacter, and Candida. So Pseudomonas, Staph, Klebsiella, Enterobacter, and Candida. Generally speaking, we use topical antibiotics in each wound that's infected for a couple of different reasons. First reason being, we want to make sure that we're using the right medication for the right bacteria. And as I said, they may be different. Second reason is because if it's deep enough, those vessels aren't working that are going to the wound. They're thrombosed, they're dead, they're fried, literally. And we're not, if we gave IV antibiotics, the wound bed would not get any, because there's no good circulation in that tissue. So the only time we would use IV antibiotics would be two separate times. Once if they were septic, because now the bacteria has become system-wide, so they absolutely need IV antibiotics. The other time would be if they were going to debride the wound surgically. And they don't have to go to the OR for this, sometimes they do it at the bedside. Surgically just means they're using a scalpel or tweezers to like pick off the dead skin. And in that case, then they would give a dose or two before, and then a dose or two after. So that they cover when the wound is open, because one of the characteristics of debriding surgically is that you debride until you bleed. So they want to get to healthy, bloody tissue, so they will debride it, but then the vessels just close up again. So one or two before, one or two after, and then that's it. I'm gonna give you some medications. They are primarily topical. In fact, yeah, they're topical. Silvadene, S-I-L-V as in Victor A, Dean, D-E-N-E, Silvadene, is also called silver sulfadiazine. So Silvadene is silver sulfadiazine. And you'll see a pattern. It's effective against yeasts, gram negatives and gram positives, so very broad spectrum. Sulfamylon, another sulfur drug. So we have a problem if patients are allergic to sulfur. And sulfamylon is mefenide, M-E-F-E-N-I-D-E, mefenide. Also broad spectrum, gram positive, gram negative, and anaerobes. Remember what they are? They grow with no oxygen, anaerobes. The problem with sulfamylon is that the drug itself is an acid. So you're putting an acid on top of an open wound. So it's extraordinarily painful. It's used, the sulfamyline is used in electrical burns and also with the open wound method of wound care, which we'll talk about in a minute. Silver nitrate is hypotonic, it's liquid, and the dressings have to be wet in order for the drug to be active. But they can't be soaking wet, because if they're soaking wet and you put them on an open wound, the wound becomes macerated, it means it becomes soft and mushy and foggy, and then it doesn't heal. Good old fashioned betadine, because it's antifungal, also antibacterial. And what they do with these drugs is they use them serially. So they don't use them, they will decide which one they're gonna use in which wound. But they only use that one medication in that wound until either the wound heals or until they start to see growth again of bacteria and the infection hasn't gone away completely, because now it means they've become resistant to that antibiotic. So then they'll change it. But otherwise, they just use one based on which bug they have until they're healed. Some adjunctive meds that can be used in addition to those are mycostatin for Candida, because Candida is a fungal, mycostatin's a fungal, antifungal medicine. The nice thing about mycostatin, it comes in a couple of different formulations. So they can use the liquid and you can paint it on. If it's a big area, you take a Q-tip and you kind of paint it. It also comes as a powder and you flick it on, it comes in a little thing that looks like a little salt shaker. And you put it on the wound bed all over, and then it just kind of liquefies and goes into the wound. They're going to be using lactobacillus, because they want to make sure the GI flora stays healthy. They will often give them vitamins and iron. And they'll often, because of the Curling's ulcer, be on some type of GI med, H2 blocker, or a proton pump inhibitor, or one of those, so that in fact they can avoid that problem or treat it if it happens. The next thing that takes up a nurse's time during the acute stage is wound care. The whole idea of wound care is to prevent infection through cleansing and debriding. You want to minimize any skin destruction. You want to assist in early closure. And you want to promote comfort. Those are the 4 goals of wound care. You almost always have to medicate for pain before wound care, because I said before, everything you do is gonna hurt them. For cleansing and debriding, it's gonna depend on how much of the body is involved. If it's, a bunch of small little ones, you can do it at the bedside and just take some gauze and some, water and a soap, just like we talked about when you do it in the beginning, and make sure that you cleanse all of them and then dress them as ordered. However, for some other ones that they're bigger and deeper and there's more of them, things like hydrotherapy, which is water, and you can either do it in a shower with one of those like nozzles that have the jet spray, and you kind of jet spray each wound. Sometimes they have a tub that you can put them in, it's called tubbing. You tub a patient, and it's, again, tepid water, and kind of like those physical therapy tubs, those big giant tubs that you can sit in, and the water swirls, so it's both mechanical and hydrotherapy, because it's movement, and all of that will help debride the wound. They also have a table that you can put the patient on with a catchment onto the bottom that catches all the water, and you, again, there'll be a nozzle, and you spray each and every wound. This hurts. It hurts. So patients need to be warm when you're doing their dressing changes, because we don't want them shivering. So oftentimes, you know, the room is like 80 to 90 degrees in terms of external temperature, so the patient doesn't freeze to death and shiver. But you are gowned and gloved and masked and everything, and it's 80 degrees in there, so like major sweat. But we have to do this for the patient. The other thing that happens, we said hydrotherapy, and I also mentioned the word debriding. Debriding is not any different than if you debride a pressure ulcer. There is mechanical debridement, where you take a tweezer or a scalpel, surgical debridement, where you're physically doing something to debride the wound. There is also enzymatic, so enzymes, enzymatic debriding. Have you all used something like Santyl on a pressure ulcer? Santyl is a debrider, and it's, I can't remember the name of it. It'll come to me. But what they do is they literally eat away at the dead tissue. Now, you do have to be careful that you don't get it on healthy tissue, because it will also eat healthy tissue. So, we're gonna debride. I really wish I could think of that name. And then surgical debridement, I already talked about. I talked about eschorotomies. There's also something in wound care called open wound care, which is an oxymoron. You know what an oxymoron is? An oxymoron is something like jumbo shrimp. Big, little, okay? Open wound care means no dressing. So the patient just has their wounds cleansed, and then they get medicated, and then they are left open to air. So this patient is at very high risk for shivering, for infection. They have to be watched very, very closely. And they usually do this for areas that are difficult to dress. So things like the perineum, maybe a joint that's difficult because the patient is moving. The other time that they may use it is for the head and the face, because it's not like a soap opera. Remember in the soap operas, they used to cover the head and the face, and then all of a sudden they were beautiful and a new actress. That's not what they do, because especially for adults, it is extremely, extremely claustrophobic, and they actually get psychotic if they leave it on for too long, like an ICU psychosis. So they often leave the face open. The last time I said that, though, the very next week on 60 Minutes, they had a guy and he was burned and his whole face was like, oh, well, there goes that thought. But for the most part, and when it's an open type of wound care, you have to be, I mean, I know we're not sterile because we're in a regular room. You know, it's not a laminar airflow room or anything like that. So, but as sterile as you can be with that type of technique is what you have to do, because they are at such high risk for infection. They're still immunocompromised, and now they've got all these open wounds open to air. The closed wound method is that wounds are covered and impregnated, either with impregnated gauze. So some of those meds that I talked about a few minutes ago, they actually come on the gauze already. Some of them you have to put on the wound and then put gauze. But generally speaking, that's what you're doing. You're doing wound care like we teach you in the lab. You're opening the wound, you're throwing away the old stuff, you're washing the wound to get all the old gunk out, and then you're putting in new dressing and covering it. Sometimes the trick with this is that there's not any place to tape a dressing on, so they use that mesh. Are you all familiar with those mesh dressings? They come on a roll, and they look like fishnet stockings. And you cut a piece, and they expand, and you slip it up and over whatever it is that you're dressing. Or you can cut it and put it around the wound, and then tape that. And this is done 2 to 3 times a day. So you can see where if the patient has a lot of wounds, you could start at one end, go to the other, and by the time you finish at one end, you gotta start on the other one all over again. So they're doing all kinds of wound care all day. The other wound that may take care of is the donor site. If the patient is having grafting done and they use their own body for the graft, then the donor site also needs to be cared for, and it's really quite simple. They usually just put a tegaderm on it, and then after they put the tegaderm, they usually leave about 1/4 to 1/2 inch on each side. What happens is fluid, the serum underneath kind of bubbles out. You don't do anything, you just leave it, and then it gets reabsorbed and it heals. And it usually takes about 2 weeks. And actually, the site can be used a second time, and a third time, and a fourth time, if that's the only site that the patient has. As long as we care for it properly and it heals properly. It can be used every 2 to 3 weeks, if they need to. Okay, surgical debridement, I already talked about, esclerotomy, I talked about, wound care, I talked about, grafting, I didn't talk about. Maybe the only thing I get to. Okay, so wound care in terms of grafting. And it's part of wound care because some grafts, if I don't finish, I'll open the audio, because there's not a lot after this, but, grafting means taking some kind of skin and covering the wound. And the reason they would opt for grafting as opposed to gauze for dressing is that you can leave it on longer and you don't have to disturb it. And the more we disturb something, the greater the chance of an infection occurring. I mean, that was the whole theory behind the central line dressings. As long as you have a clear dressing over it, and you can see that there's no infection, you only need to do it once a week. If you have a gauze dressing, you need to look at it every day. So it's the same principle. And grafting, there are 3 kinds of grafts. There are allografts, also known as homografts. Those are cadaver skins. They are temporary, and they last 2 to 3 weeks. After 2 to 3 weeks, they start getting boggy, and the body begins to reject them. They're not sewn, they're not anything. They're literally placed over the wound, and a dressing is put over them, and they sit there for 2 weeks, maybe 3, 2 to 3 weeks. We don't peek under them. I mean, if the patient says there's pain, if there's hot and redness around it, that's a different story, and it's gotta be investigated. But for the most part, we're leaving it there. Sometimes what they'll do is they'll actually put a little medication underneath and then put it on. Sometimes the graft itself has medication as part of it, and they will put it on. It's a cadaver. It's a dead person. Somebody was nice, they died, they gave their body to science, and now we have cadaver skin. There's not a lot of it. Not a lot of people are giving their bodies to science. There is another temporary graft that's called a xenograft, Xenograft. It's also called a heterograft, okay? These are often pork. So you do need to be careful with people who are kosher. They will often not allow you to put them on them. They are now also using fish skins. With the scales, they're using fish skins. These need to be changed more frequently because they break down, so anywhere from 3 to 2 weeks. 3 days to 2 weeks, sorry, not 3 weeks to 2 weeks. These are also often treated with some type of medication like silver nitrate. So if you have a wound that's a little more precarious and you don't wanna cover it for 2 to 3 weeks with a homograft, then covering it with a heterograft gives you only, 3 days to 2 weeks, and you can look at it more frequently and see it, to see what's going on. The last type of graft is an autograft, and the autograft is skin from that person. This is the final graft, this is not temporary, this is permanent. So skin is removed from the person that has the burn, so there's not gonna be any possibility that's gonna be rejected, it's their skin. And it's placed over the burn, it's not sutured, it's just kept into place again with one of these, dressings that are non-invasive. There's no tape on it, we don't want tape on this because then the tape can pull it off. So something like the fishnet or something covered with a gauze and then the tape on the gauze. And, they generally take about 2 weeks to engraft. Engraft means become part of the skin again. But after 5 days, for 5 days the patient can't really move or exercise or do anything with that area that's grafted because they don't want it to move out of place. They want it to stay where it belongs. After 5 days, they will allow them to start moving around because it's engrafted enough, and within 2 weeks, it's fully engrafted. They can become itchy, they can become infected, then they have to start all over. Not the itchies. Itchies are just part of the deal. If they become infected, they have to start all over again. One complication that can happen is that same serous fluid that I told you built up at the donor site can build up underneath the graft. And if that happens, they can take a needle and just suck out the serum. Or if it's close to the edge, they take a Q-tip and they roll it, and then the Q-tip will wick up the fluid so that if they want it to stay flat on the wound. If they don't have enough skin for the amount of wounds that they have, they can do a couple of different things. They can either expand the tissue they have with a machine that kind of looks like a pasta machine, and they put the skin in and they elongate it, and then they can cut it and put it where they need it. They can also grow skin. It's called cultured epithelial cells. And therefore it's called cultured epithelial autografting. And what they do is they take a couple of cells from the person, epithelial cells, you don't want liver cells, you want epithelial cells. And they put them in growth medium in a petri dish. They wait 3 to 5 days, and then they transfer that to like a baking sheet with culture medium, and they stick it in an incubator. And in about a week and a half, they have enough skin to cover an entire human body. Yeah.
How about the balloons?
How about the what?
The balloons.
Balloons?
Yes, the balloon, they can use the balloons also, they're called, skin expanders. If the patient has enough skin, that's, the biggest problem is there enough open skin that they can take skin away from it? If there is a big enough space, they can put in a tissue expander. Are you all familiar with tissue expanders? They are like a balloon. They're put under the skin. They have a port that sits right underneath the skin, and they add saline to it a little bit at a time, so that it grows. And then you can get more and more skin. And then they take the balloon out, and they have all this excess skin, they cut the skin off, and then they suture back together. That's a little harder to use multiple times, but they absolutely can use it. They use those for women with, breast reconstruction after cancer, so they'll put in a tissue expander. They'll expand the tissues, so they'll have enough natural tissue to be able to cover when they need to, do the surgery and remove the breast, and they'll be able to cover the, implant. So, yes, they can use those. And then the cultured epithelial cells, they don't use a lot because they're super expensive, but the technology is out there, just so you know about it. Okay, so, there are a few things that did not get covered. I apologize. I will open the, what do you call that thing? The audio lecture. You can zoom all the way to the end, it's the very last, unless you wanna listen to it again. It's almost the same thing without the stories. My husband, when I was taping them, was like, "What are you doing in that basement?" I'm like, "Oh, leave me alone." He's like, "You're telling a story." I know. So, the last two things that are probably important would be the nutritional support and the scarring issues. So it's about probably about another 10 minutes on the tape. Okay, so I will open that up. I will also, make sure if you have questions, I will check my computer on the weekends, so if you listen to it and you don't understand something, I'm happy to explain. Okay? All right, yes, wait, question?
For the next exam, do you write
Yes.
like your questions?
There'll be, the next exam is 25 burn questions and 25 eyes and ears. Okay? And you should have a familiarity with the formula and have a familiarity with the rule of nines and blended products. Don't memorize stuff, it doesn't help to memorize, have an idea, don't drive yourself crazy. Okay, so I will open that lecture, and we will start from the area that says nutritional support, and go to, actually, you can listen to the whole thing, I don't care, but the part you didn't get was nutritional support, you didn't get, scarring, and the rehab phase, which is very super short to begin with. Okay. For those of you, I'm sorry, for those of you who need to stay for the math test, I decided nobody comes in this room, so I'm just gonna go down and get it, we'll stay here.